Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. So welcome back to part 2 of the Burns podcast. I'm with Winston de Mello, who's a burn specialist, pain specialist. Good morning, Winston.
Good morning, Eric.
So last week we talked about burns issues and how we would approach burns during patient assessment and management. What we didn't mention was burned heads, head burns, scalp burns. Can you expand on that, please?
Yes, just to make sure that if you're dealing with a head and neck burn, the chances of swelling and upper airway compromise is very high. So if it's at all possible and there's no contraindication, the most important thing you can do is to sit them up. Don't worry about the swelling in the first few hours because that's not where the problem arises. The problem arises sort of 12 to 16 hours after a major burn. So that's one thing that you need to bear in mind. The other is remember if a patient has been burnt in a confined environment, there's a very good chance they'll have carboxyhemoglobin poisoning. And the quicker you give the highest possible supplemental oxygen, the carboxyhemoglobin will dissociate from 320 minutes to 80 minutes if you're giving 100% oxygen. The other problem with the fluctuating levels of consciousness, besides hypovolemia or a head injury, it could be a systemic poisoning like with cyanide. If the cyanide level is very high, the patient usually dies at the scene. But the less patients with less levels, you may be tempted to treat them with hydroxycobalamin, which is cyanokit trade name. But just be aware that there is an incidence of acute kidney injury in these patients. So you must be pretty confident that you've got the diagnosis before you try the antidote. That's really what I wanted to complete.
So I know that AKI, like the kidney injuries, is a different podcast, but can you briefly discuss what would, as a pre-hospital provider, what would we do to prevent the kidney injury secondary to this head burn?
I think the most important thing is to see what the urine output is and see the quality and the color of the urine so that you're detecting hemochromojones. The classical treatment of a rhabdomyoglobin is increased urine output and alkalizing the urine. So that's essentially it.
So high urine output for both injuries, the burns as well as AKI.
Burns only if there is evidence of a hemochromosome like rhabdomyoglobin.
And the burns head injury that we have during our scenarios in Malta is always the big surprise of our casualties when they see what Laura Bella Vella can do with the live casualty with the burn head. How are they covering the head with cling film? Because that's like the first thing they do after cooling. What's the trick on cling film on heads?
Well, the most important thing is to make sure that the burnt area is covered as soon as you've cooled it or cooling it through the cling film. But the most important thing is to keep the eyes, nose, and mouth exposed. That's the main thing. But certainly, a burn involving the scalp is going to be a complex wound because of the hair and because of the easiness in which secondary infection occurs. So, using a cling film allows you to look at the complexity of the wound without actually undoing the dressings. So that's the main comments I'd make.
And head burns horrifically painful, like all burns. What are we talked a bit about pain management in the first issue of this two-part series. What are some other options you have? What are alternative pain options you have for burns?
Okay, let's look at the most common opioid, which is morphine. We know that morphine works, but we also know that morphine in major trauma and major burns can be a double-edged sword because there's a tendency to induce a cardiovascular collapse, which is why we moved on to fentanyl. But it may be the only drug you have, in which case using it by titration is fine. A lovely thumb rule is your morphine requirements in the first 24 hours after a major trauma or burns is equal to 100 minus the patient's age in years. That was a paper produced by Pamela McIntyre in 1996. So body weight is not a good indication, which is what we used to follow work done in Italy during the Second World War by Beecher and colleagues. So that's the first thing. So a young man of 20 will require 80 milligrams in the first 24 hours, and a 60-year-old require 40. It's a very nice, simple guidance. Fentanyl is more cardiostable, so if that's available, it's an alternative use, but its half-life is shorter, so you may need more top-ups. And then finally, obviously, ketamine is versatile because you can use it either for analgesia or possibly even anesthesia. And we'll talk about that when we talk about fasciotomy and escharotomies. But as I said in my first part of this podcast, ketamine is the ideal drug for neuropathic pain. And as we know, a burn anywhere in the body produces a neuropathic pain, and therefore the quicker you detect it, the better it is. And then finally, when the burn's a few days old, the use of topical morphine on a burns, dissolved in sterile water and sprayed onto the burn wound after debridement, is another alternative and quickly covered by cling film, and patients get a reasonable amount of pain relief to warrant its use in this route.
I remember in the burns courses you've taught in Malta, something about ketamine showers. What
Yeah.
is a ketamine shower?
A ketamine shower in the burn center. We have a shower room attached to the major wound patients, and so you would have a cannula in the patient, and the patient would be sat in the shower. You would have one assistant holding the patient, the anesthetist, i.e., me, giving ketamine boluses to maintain procedural pain, but not anesthesia. And obviously, because you're in a shower, electricity becomes an issue, so you can't have electrical monitoring. And basically, we do change of dressings, cleaning of wounds, including the use of brushes to debride skin. And most of the time, you can get a whole session of about an hour done within those conditions. I used to use a little bit of midazolam for the for the some of the uh, side effects of ketamine, like the sounds and the noise and the visual effects. But I don't bother anymore. I just tell the patients beforehand that under a ketamine shower you might get bizarre dreams and hallucinations, but it's nothing to be worried about.
So that brings us into a whole nother topic about wound cleaning for burns.
Yes, I think it's in the initial phase, the wound is sterile, and that is why we use cling film to reduce secondary contamination. It's important that the person doing the wound cleaning undergoes hand washing, has the appropriate PPE, and works off a clean working surface. Well, that may be difficult in osteo conditions, but generally the cleanest conditions that you can. We recommend the use of baby wipes initially to clean the burn wound, and then followed by octenolin, which is a combination of tenadine and ethyl hexaglycerine, which is best used for wound cleaning. The alternative is 0.5% silver nitrate, which may be available in osteo conditions, but you have to be aware of the toxicity of silver. And when you're doing the initial wound cleaning, uh, it's important to reassess the total body surface area burned and the depth, because if you remember, it's difficult to differentiate between erythema and a burn in the initial phase. But as time goes on, there may be a better demarcation. And the chances are that the percentage burnt will decrease for the reasons we discussed last time round. The other thing is there's no point in putting antibiotics if there's dead tissue. Now, you can remove dead tissue using a small fine scissors and forceps. And that is, if the tissue is dead, then obviously it's not going to hurt. But don't fall for the mistake of using topical antibiotics, because that's not a substitute for the debridement of dead tissue. The other trick I've learned is to take a syringe, a 50-60 ml syringe, and just put a very tiny 25 gauge needle onto it and spray sterile water or sociably clean water. And this produces a hydrojet, and it's also known as hydrosurgery. And that can get into crevices and bring out the underlying uh, uh, dead tissue up to the surface and being washed away. In terms of dressings, the simplest is dry gauze dressings or clean linen. It just depends on what's available. But remember, both of these tend to stick, and removal can be quite painful. So your choice and schedule for how long and for how frequent you do your burn dressings will depend really on the mission. So essentially, treat the inspection of the have a regular inspection of the wound. Treat with antibiotics topically if there's local infection like cellulitis or lymphangitis, or is intravenously if the infection is spreading or the patients become septic. And our final choice for redressing is Acticode, either the 3 or 7 day version. And we really have tried to make it very simple, because the availability of dressings in complex wounds is massive. So our option one is you have 3 layers: the contact layer, the absorbent layer, and the holding layer. So our first option is to have Mepiplex AG, which is silver impregnated, as the contact layer, followed by Dimax, which is an absorbent layer, and then Mefix, which is the holding layer. The alternative is for the contact layer, use Gelinet, which most of you will be familiar with. It's paraffin gauze type, followed by the plus the Acticoat silver impregnation, with Gamgee, which is basically heavy duty cotton, as the absorbent layer, and crepe bandage as your holding layer. So those would be our uh, uh, ideal choices in an osteo environment, but you would have to preload and pre-stock some of the equipment beforehand.
For the medic that's going to be working in, or for companies or for expeditions, that they have two options. They have cling film and they have gauze. They'll probably have crepe bandages for the third layer. So, what is your suggestion for someone treating a wound for 4 or 5 days as they walk him out or medical evacuate, and he only
Yeah.
has cling film and absorb and gauze?
Okay, so in that case, you would use a cling film for the first day, because you need to see the direction of the trajectory of the burn wound. Is it becoming dry or is it becoming wet? In which case, use cling film for the first, say, 24 hours, and then once you know whether the wound is wet or dry, you can use your layers with whatever you've got. Gauze and Gamgee, gauze, or crepe bandage seem more universally available, and then change the dressings once it's been soaked through. That would be a good sort of way of working.
Okay, so cling film, just cling film for the first 24 hours, and then if it's healing, if it's a dry, then you can do just gauze directly on the burn, followed by crepe bandage.
Yeah, you might have to soak the area before you take it off, because it'll have stuck to the underwater.
Yeah,
What you don't
definitely.
want to do is to remove the healing skin, the re-epithelialization process. You don't want to make that process delayed. So be careful when removing it during a burns dressing change.
So how often do we change burns dressings in an austere environment?
If it's soaked through, it needs changing. If it's smelling, change it. Those would be the two main things.
So is there a time frame if you see it's not soaked through, if it's not smelly, how long do you leave that bandage on before you change it?
I think inspecting probably 24 to 36 hours, something like that,
Okay.
in a non-complex wound. But the reason why I like the cling film in the initial phase, first 24 hours perhaps, is that it allows you to see how the wound is behaving.
Hmm.
And I think that it'll. There are so many factors that you need to consider. One is the availability of supplies. B, have you got the resources in personnel to be able to do it? Burns dressing is not easy to do single-handed. So I think there are logistic factors that will also come into play, and then obviously the presence of evidence of lymphangitis, cellulitis, or systemic shock would also mean redressing the wound more often.
And you said as far as topical antibiotics, what only if you see inflammation and indication of topical infection?
Correct. So, in other words, you can mark the area with indelible ink, and if that's increasing and there's evidence of cellulitis, then you could probably think of topical antibiotics. The problem is the availability of antibiotics, and the other plea I make is do not use agents that may be available in osteo conditions from local pharmacies because they may be toxic. And the one I think about is silver. Silver is antimicrobial, and you know it's usually used in 0.5%, but you just don't know the quality of uh, the mixtures you get from isolated pharmacies. So just be wary of doing something for the first time without knowing the safety of the product.
And when you change your so let's say you're doing everything correctly. You're an excellent medic. There's no infection. 24 hours you change the bandage and you get it wet and you pull it off carefully. Do you do you do soap and water or how do you clean it before you put the next bandage on?
I think soap and water is a perfectly uh, useful way of doing it. But the other one I would recommend is hydrosurgery, which is basically using the jet of water from a syringe and tiny needle to try and lift off any debris, and forceps and sharp scissors to cut off dead tissue. Those are probably the most important things you can do.
How do you know? So irrigation, brilliant. How do you know when you've irrigated enough?
If there's nothing coming up, like you know, when you use hydrogen peroxide, you get all those bubbles and all the debris surface. It's
Hmm.
when the washout of the burn area doesn't looks clean visibly. That's it.
That's a brilliant rule of thumb. And you talked about topical antibiotics. What other topiceuticals are there for the osteomedic?
Well, again, I think there are some things that are available in osteo conditions which you might have to depend on. The first one is using a mixture of lidocaine and morphine in a plastic bag for burns on the hands and feet. You can just put in 20 mils of 1% lidocaine and 20 to 40 milligrams of morphine into a plastic bag, wrap it around the affected uh, either lower or upper limb, make sure it's watertight, and the patient can then move their fingers or move their toes, getting analgesia. And the extra benefit is lidocaine is bacteriostatic, so at least will keep the burn the amount of microbiology colonies to a minimum.
So let's play this out. So you're in an austere environment. You're not getting out for 3 or 4 days. You had someone with a 18% total body surface area burn. You've gone through as you stated, and it's healing perfectly. So every 24 hours you're changing bandages. You're winning cool points because you're doing really well. So where do we So this is part of sheep vomit and prolonged field care, isn't it? So are we just having him sit? Are we having him walk around? Is there physiotherapy, range of motion? What are we doing with him?
Okay, I mean that's a good point. Let's first talk about some of the topiceuticals that might be available in your environment. Honey, and it doesn't have to be medical grade honey. If it's available, that on a wound is very good uh, for uh, uh, for being bactericidal by virtue of the fact that it's hygroscopic. It'll make a wet wound drier, and it's ideal. The other one, which is probably not as easy, but you might have to follow, is the in an older burn, like say maybe 5 days plus. The use of peels from the plantain or papaya, which has a natural enzymatic debridement. So that could be part of the topical application you can put on to help digest the eschar from forming. And then finally, for the perineum, which is got a bacterial microbiome of its own, don't forget to use something like metronidazole just to prevent infections in the dirty genital area. And so metronidazole, which is normally used for bacterial vaginosis or pelvic inflammatory disease, as a paste can be applied to the perineum as part of the topiceuticals.
Is there any other topiceuticals or any other options available that will help the burn patient?
Well, the most important thing is high energy feeding solutions for the patient. Remember, major burns are a hypercatabolic state, so it's like your requirements for calories are increased, and you have to use the Harris Benedict equation, which takes into account your basal needs, your stress factor. Are you lying down, or sorry, the degree of the burn, and the activity factors. Are you staying immobile, or are you moving around? Um, so feeding is important. Use the oral route early, if at all possible, for anything above 15% TBSB. Um, and to cover the possibility of stress ulceration, use a PPI cover like omeprazole 20 milligrams once daily. And you might be in an area where you get all these yogurts, sauerkraut type foods, which are very rich in probiotics. That will promote the health of the fecal microbiome, and that has also a great impact on the gut-brain axis. So these are the things that you require to think about when it comes to feeding. However, to provide high energy feeding solutions for burns, you need to be prepared for it. And the one that I found as a useful guide is from the Oxford textbook of humanitarian medicine, where they've got a recipe using skimmed milk, edible oil, sugar, and banana. And then to which there's added sodium salt, sodium chloride, as calcium containing antacids, multivites, ferrous sulfate, folic acid, codeine to prevent or reduce diarrhea, and egg to provide protein. But you have to be careful of your source of eggs. And this particular solution gives you roughly 1,415 kilocalories per liter. And the authors reckon the average patient can manage 3 liters. So you're going to get about 4,245 calories a day. And you divide it into 6 to 8 feeds. So there's a break and administer it via a clean syringe through a nasogastric tube, and then clamp the nasogastric tube after each feed. And if the residual volumes before the start of the next feed is very high, try prokinetic. And one prokinetic I will recommend to you is erythromycin, because erythromycin works from a completely different receptor, and its prokinetic effect is superb. So that would be my overall high energy feeding solution as an example.
If they don't have anything other than just camp food, is that enough? Would you suggest letting them eat what are using NG feeding for anything or what oatmeal or if the only thing
I
you
think
have is what's in the camp?
I think what you'd have to do in the don't forget those pre-packs are high calorie anyway. But your challenge is going to be how do you turn it into a soup-like mixture to be able to feed it down the nasogastric tube. That would be my observation.
So these protein shakes are very popular. All these knuckle draggers have them. Would that be an option?
Oh yeah, if you've got reserves of that, either pre-planned or just by coincidence, yes. I think the more calories you get into the burn patients, the less chance you have got of weaning just your muscle mass is just going to decrease. I mean, just to give you an example, if you're bedded down with a severe flu for 3 days, up to 10% muscle mass can be involved. So you have to be on top of the calorie provisions, and I think some of the examples you've mentioned are definitely usable, and also probably easier to manage because you don't have to worry about making your own concoction.
So you've treated them. You're doing your 24-hour bandage change, and you're getting him on the mend. So from here, what are we doing to make his life better? Palliation and integration in letting him read, or getting him uh, entertained, or what are you doing with the casualty whilst you're waiting for medical evacuation?
I think there are two things I would like to mention. The first one is what physiotherapy interventions and positioning of the body needs to be, and the second is palliation, which I'll come to in a second. Really, for physiotherapy, the most important thing is chest care, and percussing or cupping the chest to try and loosen off secretions, nebulizing saline to help mobilize the secretions that may have dried up, and then putting the major joints through passive and active range of movements. So, and then followed by splintage. So for the neck, you would avoid the use of pillows and just keep it in an extension. For the fingers, you would wrap each one individually with gelinet gauze and bandage, and the whole hand with a plastic bag with chlorhexidine, and then tape around the wrist. The forearm and hand fracture or complex injuries, just splint the palm, hand, and forearm, but do not wrap the hands in a fist, but keep the thumb web open with dressings. Arms and legs kept extended, and feet in a boot position, and this will avoid stiffening of the major joints, which will reduce the amount of time they will have to do in rehabilitation. There is nothing worse and more painful than mobilizing a stiff joint which has been kept splintered without going through a regular physiotherapy uh, uh, interventions. And I again point out to the Australian burn victims in the Bali bombings. They were mobilized even when they were intubated. Now that needs a lot of resources and personnel. The point is, if you can get them going, keep them mobilized, keep them awake during the day, asleep at night, and make sure that their day-night cycles, circadian rhythms are kept in place. Talk to them. Communications, important. Tell them what is happening. Give them a view on the next step or the next transfer. And when it comes down to discharging them back to the community, I think it's important to get family members trained in the importance of these things, even if it can be very painful, like incidental pain, which is the pain produced by mobilization, is one of the most difficult pains to treat because it's short-lived but extreme severity. So feeding, mobilizing them, and making sure that their wounds are not getting hypertrophic, and if those kind of issues are arising, then they need to try and get them to a better source of medical care.
Whilst you're waiting, you uh, you see that the peripheral circulation's dropping, or their difficulty breathing is getting worse. Can you describe or discuss the escharotomy fasciotomy option that would, or when the indications, or what's going to be the trigger for you to make that difficult decision.
Okay, an escharotomy is uh, I would say almost essential. So you're more likely to need to do it in an osteo environment. And the reason for it is that if you have a circumferential burn of the chest, abdomen, or the long limbs, you're going to get uh, impaired perfusion, high compartmental pressures, which need an escharotomy. However, if you've got good perfusion, then maintain the limb elevated, optimize the fluids, monitor the limbs, and if you can measure compartmental pressures, that would be useful. But if you've got the chest, circumferential chest or abdomen burn, you're not going to be able to ventilate. The patient's not going to be able to ventilate, or you're not going to be able to mechanically ventilate them because it acts embarrasses the chest wall movements. So you're going to have to do an escharotomy. Now, an escharotomy has to be done in certain directions and certain lines, and these are the lines of Langhans, which make the healing optimal. So that's the first point. The second point is when you cut along an eschar, you need to start from normal tissue through the eschar and on through onto the other side into normal tissue. So it is very painful. And remember, the area around an eschar is very hyperemic and very tender. So you require good analgesia. And you've got two choices here: intermittent IV ketamine or the use of methoxyflurane inhaler. Now, the problem with escharotomies, you can bleed a lot. It's easier said than done to say avoid cutting blood vessels, but obviously, if you've got a blood vessel, you can clip it and tie it off, or you can pack the wound with alginate dressings, which is made from seaweed, or even easier for our osteomedics is to dissolve a milligram of epinephrine and dissolve it in a thousand mils of normal saline, use some abdominal swabs, soak it in, and apply it to the wound so you get some hemostasis. You can also use hemostatic bandages, pressure dressings, elevate the limb if it's the limb that's affected. And TXA 1 to 2 grams IV is also potentially useful. But just remember, escharotomy bleeding can be very bloody, especially if you've never done it before. Fasciotomy, on the other side, usually will occur with a high voltage electrical injury, crush, or forearm fractures. And essentially, it is not something that I would recommend you do unless you've got top cover telling you what to do, because the way in which you do a fasciotomy needs to get all the compartments done. Otherwise, it's a waste of time. And these procedures, fasciotomy too, can be very bloody.
Is there any indication of using a wound vacuum for burns?
Now that's a very good suggestion, and I saw your improvised negative pressure vacuum for complex wounds at Malta recently. I'm going to ask you to explain how you do it. But do you remember I said to you it depends on the trajectory of the wound. If it's going to be a very moist with a high exudate, or is it going to be a dry wound? And essentially, if it's dry, you wet it, and if it's wet, you dry it. So if you've got a lot of discharge from a complex burn wound, then negative pressure drainage is ideal. And perhaps at this stage, you can explain how you would do an improvised negative pressure contraption.
Well, we used the CPG from the JTS website, and they discussed wound vacuum. And medically, you want 120 millimeters of mercury, so that's a fair amount of suction. So we were struggling to find a way to measure that in an austere environment. So what we did is we got a wet to dry dressing on the wound, and we used super thick, super wide Tegaderm to completely occlude that. And then we put an NG tube into the middle of the wet to dry dressing and used a Toomey tip 60 mil syringe to pull suction, and we just pulled as much as we could, and it did create a suction within, but then we were curious on how much suction that was, and then one of the SF medics that was on the course came up with a oxygen tubing loop with water in it, and we put a BP cuff on the end of it, and we've got a good indication that a fully plunged 60 mils fully syringe was enough suction for 120 millimeters of mercury. So it's not scientific. We can't prove it. We can't publish that yet. But we are seeing that if you just use a Toomey tip syringe with a NG tube or oxygen tubing into the middle of the wound vac, you are getting sufficient suction.
I that's such a brilliant concept, because it's using equipment that's maybe easily available at their location. And just to remind the listeners, this contraption that you've described for negative pressure wound cover is also useful for any complex wound, sacral sores, pressure sores, fungating cancers, etc., etc. So I think in terms of complex wounds, where there's poor healing or maladjusted healing, where the exudate is high, then negative pressure wound dressings are contraptions are very, very useful. So not just for burns, but for any complex wound where there's a high exudate level.
Winston, do you have any other concepts that you would like to discuss about prolonged field care of wounds, of burn wounds?
I think I've discussed most of them. I think the most important thing is, remember what the requirements of the burn surgeon is going to be when when you're finally able to transfer your patients to a higher level of care. So my reasons for going for the products that we've discussed in this podcast is basically based on SF Medic's requirements for working in the field in osteo environments. So probably the most important thing is preparation before the mission, trying to make sure that you can look after a major burn, and in terms of dressings, in terms of wound cleaning. No, I think that in itself would be sufficient, because then at least you have ticked the boxes before you get out there, and you know what you can do with a major burn, other than just going for the CABCs.
I would also like to mention that you did a fantastic PFC burns lecture at SOMA in 2021, and if anyone wants to purchase that, you can do so on the SOMA website. It was a really well thought out and presented topic. Thanks for doing that.
Thank you.
All right, Winston, thanks, and we will see you again next month.
Look forward to it. Happy New Year to you and to all our listeners.
This has been a presentation from the College of Remote and Offshore Medicine Foundation. If you would like to earn CPD credit for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credits, free access to the virtual field guide, and discounts on our e-learning courses. You can join the team on the college website, which is Corum, COROM, corum.org.